Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Today we are starting a new chapter in obstetrics, which is medical disorders in pregnancy. Within this very short presentation, I want to set your mindset for the whole chapter. I want to give you a transferable clinical approach through a common thinking framework in order to be able to manage these problems appropriately. Let us start. Theoretically, almost any medical or surgical condition can coexist with pregnancy. Some women enter pregnancy with a known chronic disease, and some have unrecognized disorder revealed by pregnancy, and others develop an acute condition unrelated to the pregnancy. The obstetrician, therefore, needs a broad clinical perspective and must work closely with physicians, anesthetists, neonatologists, and different subspecialties to be able to manage this complicated pregnancy. You need to take the whole approach. Studying these topics is important as these conditions can have high clinical consequences. Certain disorders deserve particular attention in pregnancy. The clinical significance of each condition depends on 6 factors. Some conditions might fall within one or more of these categories, which are shown in this slide. Condition, for example, like bronchial asthma, diabetes mellitus, thyroid disease, epilepsy, and hypertension are frequently encountered in women of reproductive age. So they naturally form an important part of obstetric practice. Pregnancy also have certain physiological change that, for example, increases plasma volume, cardiac output, ventilation, and renal filtration, while also producing insulin-resistant, substantial ion demand, and hypercoagulable status. These adaptations are physiological, but they may increase the risk, change the presentation, or worsen an existing disorder. For example, a compensated cardiac disease may become symptomatic during pregnancy, and pregnancy increases the risk of anemia and venous thromboembolism. Some diseases are uncommon but carry substantial maternal mortality or morbidity, such as pulmonary hypertension or severe renal disease. Others have major fetal implications, including congenital anomalies, stillbirth, or neonatal affection, for example, diabetes, or growth restriction like in hypertension, and some conditions carry medication safety issues like epilepsy and breast cancer. It is also crucially important to understand that risk may be reduced through disease optimization, vaccination, for example, medication substitution, or an assessment and a planned multidisciplinary pathway before conception. Here I want you to consider this central analytical model, which make you understand the relation between the pregnancy and the disease. Pregnancy affects the disease, and the disease affects the pregnancy, and the treatment also influence both of them. First, we need to consider the effect of pregnancy on the disease. Think of the physiological changes of pregnancy, which might alter the disease activity, might alter the symptoms, laboratory values, and drug pharmacokinetics. In normal pregnancy finding can also mimic diseases like tachycardia or edema. Secondly, consider the effect of the disease on the pregnancy. Maternal complications may include decompensation, thrombosis, or the need for maybe intensive care. Pregnancy outcome may also include miscarriage, congenital anomalies, fetal growth restriction, indicated preterm birth, and stillbirth. The third consideration should be towards the treatment. You know that medications can adversely affect the growing fetus. On the other hand, withholding effective maternal treatment may itself endanger both the mother and the fetus. So the correct approach is therefore not to avoid all medications, but to compare the risk of untreated disease with the known or potential risk of the medication. Those requirements may change because of the altered plasma volume, because of the protein binding, because of the renal clearance, for example. So you need to think of managing two patients with one integrated plan. Maternal stabilization generally provide the best fetal protection, while fetal considerations influence the drug choice, influence the timing of birth, for example. So the pregnancy may improve, worsen, or unmask, or alter the presentation of the disease. The disease may affect maternal health and pregnancy outcome. The treatment decisions require a balanced maternal and fetal risk assessment, and pre-pregnancy planning can modify all three parts of the interaction. Here, I'm giving you a structure for counseling and management across the reproductive pathway. For all medical disorders encountered in pregnancy, you need to follow this management plan in 4 parts. Before the pregnancy, assess whether the woman is currently fit for pregnancy and whether the condition is stable. Review previous complications, disease severity, organ function, inheritance, and the possibility that pregnancy may be inadvisable. So you need to review all medication, discuss contraception until optimization is complete. In early pregnancy, you need to confirm the diagnosis and gestational age, document baseline clinical status and investigations, and stratify maternal and fetal risk. Clarify which team members are needed for the multidisciplinary care. And during the pregnancy, tailor follow-up to the condition. Maternal monitoring may include symptoms, examination, blood tests, drug levels, and fetal monitoring may include anomaly assessment, serial growth scan, Likert assessment, and fetal surveillance. Medication doses and goals may be adjusted as pregnancy progresses. The 4th part of the management, the 4th part, is for birth and postpartum care. You need to decide timing, place, and mode of birth according to obstetric and medical indications. Consider anesthetic review, thromboprophylaxis, intrapartum monitoring, fluid management, neonatal care. You also need to remember that postpartum physiological shift may precipitate deterioration. Review the medications compatibility with breastfeeding, long-term follow-up, contraception, and advice for future pregnancy. So your core question should be, what should be done differently for this patient with medical disease because she is pregnant? Each disorder management should follow this same structure. That counseling before the pregnancy, assess the risk and establish baseline status early on, monitor maternal disease and fetal well-being throughout the pregnancy, and plan birth, anesthesia, thromboprophylaxis, and postpartum follow-up. Now we reached near the end of this presentation. I want you to give an example of a disease from each category. For example, you think of a disease that is common in the reproductive age. You think of disease or diseases that due to pregnancy physiology, their risk of development increases or their presentation or consequences increases. Give some examples of diseases that carry high maternal morbidity or mortality, and examples of diseases that have fetal and neonatal impact, and others, those with medication safety issues. You remember that overlap is expected. For example, diabetes is common, is altered by pregnancy physiology. That's why the risk of developing diabetes in pregnancy is higher, affect fetal growth and neonatal adaptation, and it also needs monitoring of the medication. Epilepsy is an illustration of the need for balance between seizure control and fetal medication exposure. Again, it is a common disorder in the reproductive age group. Cardiac disease illustrates physiological stress At the same time, it carries a significant risk of maternal mortality and morbidity, and it needs pre-pregnancy counseling. So you can use this framework of category of clinical significance in every subsequent topic. Remember, one disorder may be important for several overlapping reasons. So the aim is not to find one correct box, but the aim is reasoning. You should justify why pregnancy changes the importance and the management of this condition. And you should also be able to justify why certain conditions need to be elaborated on in more details. Thank you for your attention. And I just want to remind you that for any subsequent disease or lecture, you just before the lecture in 2 minutes think of the clinical significance of that condition in pregnancy and compare it, your thinking with your pair in terms of these 6 factors. Thank you very much and bye bye.